Hello, I'm Dr. Francisco Ponce, and I'm a neurosurgeon at the Barrow Neurological Institute. And this video is about deep brain stimulation surgery. So this is similar to what I talk to patients about in the clinic. So if you are scheduled for an appointment with me, you can use this as a resource to prepare for your visit. And if you've already seen me, this is also something useful to kind of go over with your family as you decide on how to proceed with surgery. When considering an operation, it's always important to be aware of the risks, the benefits, the alternatives, and the indications for surgery. So that's some of what we're going to be going through here. I do this surgery for primarily Parkinson's disease and essential tremor. We also do this for dystonia, and then there's some experimental indication projects as well. So what this is that I show in this slide, this is a patient diary. And they do these diaries for clinical trials in Parkinson's disease. So I'm going to talk a little bit about Parkinson's specifically right now. Here we have the hours during the day, 7 a.m., 8 a.m., 9 a.m., midnight is over here. Meals, breakfast, lunch, and dinner. Medications, Cinemet, Mirapix, and Ativan. And this person takes it 4 times a day. And what this illustrates is the on time, meaning that symptoms, Parkinson's symptoms are under control, and off time, meaning that the symptoms are not controlled. So when treating any kind of condition medically, the goal is naturally to have 24/7 control of symptoms. So when you have diabetes, the pills that you take are intended to control your blood sugar 24 hours a day, 7 days a week. Same thing with your blood pressure when you take medications for hypertension. Well, it turns out this is not always the case with Parkinson's disease. Levodopa is the cornerstone medication for Parkinson's disease. This was introduced in the late 1960s. This is a miracle drug, completely changed the game for Parkinson's, but it turned out that in the 1970s they started seeing these so-called fluctuations. So people would take their medication, they'd be on, meaning their symptoms are controlled, in this case for an hour, and then it would wear off. And they'd go a couple hours before the next dose would kick in, and they'd be on again here for an hour and a half. So these ups and downs, these are the motor fluctuations, and people would not be able to predict when they'd be on or off. I have some patients taking medication 6, 7, even 8 times a day. So these fluctuations in symptoms coupled with dyskinesias, and dyskinesias are kind of wiggling around, that's a side effect of medication. Those became kind of the problems, the complications of medical therapy. And that is why in the 1980s, people started performing surgery for Parkinson's disease again. The deep brain stimulation has been performed since the late 1980s, and we have a good safety track record and understanding of its efficacy. Over 140,000 patients have undergone this operation worldwide, and we have had clinical trials where people have been randomized to best medical therapy versus surgery, and we've learned a lot from these. So in a nutshell, what deep brain stimulation does, it kind of captures that best response to medication and stabilizes that response. So in this clinical trial by the Veterans Administration, the VA trial, people gain on average 4.5 to 5 hours of on time without the troublesome dyskinesias. So capturing that best response, stabilizing that response, and reducing or eliminating the dyskinesias. So this is like a pacemaker for the brain. So just like a heart pacemaker would correct abnormal heart rhythms, the brain pacemaker corrects abnormal brain rhythms. So there are nodes within the motor circuit in the brain that we know if you place an electrode and we apply chronic electrical stimulation that we'll see the benefits of tremor or the benefits of Parkinson's disease. So this is an MRI of the brain. The eyes would be a little bit lower here. These are the roof of the orbit. And this structure that I outlined in yellow here is the globus pallidus interna. And it's a symmetrical structure. There's also one on the other side. And here I mag up a little bit, and the arrow points to sort of the sweet spot where I target. So I split hairs, picking the right place to put the electrode. And I also split hairs making sure that I'm selecting a trajectory that's safe, making sure that we're going safely, avoiding things like a blood vessel. So this is an MRI with contrast. So you can see the blood vessel here, that white structure. and I'm entering the brain, and I'm staying inside of the brain until I get to my target. And so there is a risk for bleeding with this operation, and that risk is pretty small. I've placed over 700 of these leads, and I've not had a situation where I've placed a lead and had a large bleed that's created an emergency. I have had swelling, and I have seen some small asymptomatic bleeds, but nothing sort of catastrophic or emergent like this. So split hairs, picking the right target, and also picking the right trajectory. So this MRI is done usually the day before surgery. On the day of surgery, you go back to the operating room, and while you're sedated, I place this frame. And this frame, this is called the Lexel frame. This has been around for, I think, over half a century. And what this allows us to do, in this case, we snap on this box. It has little markers on the side that can be read by the software that we use to plan the surgery. And this allows us to calculate the set of coordinates to put this whole thing together. So there's the shoulders, the neck, the head, and there's the frame that's affixed to the head. And we can place all this, the rest of this contraption together. There's little etchings that are the numbers, so we have all these coordinates. And this allows me to place a wire through a hole about the size of a dime and hit a target about 8 centimeters deep within 1 or 2 millimeter error. So I'm going to show you a little bit about what this looks like here. So this right here is the Stimlock. So this is by Medtronic, and this is going to be underneath the skin, so it's right about there. So you can feel a little bump underneath your skin. And so this clear plastic along with the screws, that's what locks the wire in place. So you don't end up with a hole. I make a hole about the size of a dime here, but you end up with a little bump instead, and that's what's underneath the skin. And it's through that hole that I place the wire. So once we have access to the brain, again, this is a surgery that's traditionally performed awake, and with Parkinson's, off medication. And this is something I'll talk about a little bit more in depth later, but suffice it to say, the vast majority of operations performed with DBS are done in awake patients. That's standard. And once we have access to the brain, I place small little micro wires that I can use to record individual cells. So we can actually hear them firing on the computer, and it sounds sort of like eggs frying in a frying pan. And that basically shows that I'm in the right spot and that I'm hitting the cells that are my target. And I'll have people move their arm up and down and hear the cells changing in their firing pattern depending upon movement and other activities. So once I like what I hear, then I pass the actual DBS wire down the same path. And this is what it looks like. There are 4 contacts, and they span about 1 centimeter. And this is what it looks like here. So the neurologist who does the programming can pick which ones of those electrodes he or she wants to use. But you can see here, I'll mag this up so you can take a look. This is the actual wire, so it's pretty small. And so that's what goes into the brain, and it gets locked in by that plastic device I showed you earlier at the skull, and then gets tucked underneath the scalp, and behind your ear there's another incision, and you can actually feel this connection between the delicate brain wire and the hardier neck wire. So that's a little connection that you can feel underneath your skin, and then it passes underneath the skin behind the ear to about a 5 centimeter incision below the collarbone, which is where the pacemaker goes. So the placement of the pacemaker is in a second operation, but it's done at the same time. So overall, the complete operation, if you start at 7:30 in the morning, we're usually done between 11 and noon, placing the entire system. So at the end of placing the leads, placing these little wires, I get a CAT scan. So this is, again, my surgical planning system. This is the software I use to plan the operation. And I've taken a CAT scan, and now I can see the actual electrodes. So this is contact 0, 1, 2, and 3. I say, all right, this little red dot is right where contact 0 is, and it tells me where that dot is compared to the plan, compared to where I said I wanted to go. And in this case, it's 0.5 millimeters, so that's basically a bullseye, and that's what I check on every patient after placing the leads. So that's how I verify my accuracy. Any operation, there can be wound complications, and you can see here, again, this is this little bump right here. That's this guy right there underneath the scalp. And the incision is a semicircular incision that goes around. It's like a flap that goes around the hardware. So the hardware, I try to keep all the hardware away from the incision, and that helps with the wound healing. So I've not seen a complication with wounds falling apart with my DBS patients, and that's about 400 patients. But certainly we see wound complications in surgery, in even my experience for other indications. So a little bit about complications now. We've talked about bleeding. We've talked about wound complications. Confusion is something that we can see. Interestingly, when you put the wires in the brain, say somebody has a tremor, right? Just putting the wire in the brain can stop the tremor. So I have patients the day after surgery, they're drinking their coffee with their hand that they couldn't do before, and the pacemaker's off. So the battery's not actually on, but they have a clinical benefit. And the reason for that is what we call a microlesion effect. Just placing those wires in the brain can result in swelling at the target site, and that swelling actually helps. In fact, deep brain stimulation replaces ablative surgeries, where you'd actually make holes in the brain, burn a hole in the brain, which have clinical benefit. So the swelling helps with the tremor, but that same mechanism by which swelling can develop, we can also see swelling higher up, and that can result in something like a concussion effect. And we see this more in the elderly, people in their sort of mid to late 70s, early 70s, not as much in earlier patients, but confusion is a possibility. So confusion, bleeding, and wound complications we've discussed. What about something catastrophic? Death, coma, stroke, paralysis. The risk for something like that happening is not zero, but it's very small if you're healthy. So if you're a healthy patient, these risks can be kept to a minimum. So here are my speed bumps, the ones that I've seen. So I did these numbers a few months ago, 365 patients. I've had 3 infections, and actually these 3 were all within my first 40 patients. And I tried to salvage these systems, open up the wound, wash out, give antibiotics through the IV. A lot of strategies trying to save the system because patients were doing well, they liked the system, they liked the therapy. But in all 3 of these, I had to take the whole system out ultimately. So I went 0 for 3 with these. So my recommendation, if and when this happens again, is to completely remove the entire system, clear the infection. We're basically pressing the reset button, and then we can revisit reimplantation once the infection is cleared. Lead repositioning in the brain. So what that means is I place these leads, I think they're in the right place, patient goes for programming, and either because of side effects or else because of lack of clinical benefit, it turns out that we end up recommending going back to surgery to reposition the lead, put it in a different place, 3 millimeters away from where I placed it. So that's happened twice out of almost 400 patients. We're at 393, I've got the number later in this talk, and over 700 leads. So it's a small risk, 0.5% here, but it is a return to surgery and it is a risk. Hardware failure. So what that means, I check the circuits. This whole thing it's a circuit. We check the circuits, make sure all the wires are connected properly, and I don't leave the operating room until I see that we have good circuits. So sometimes I've had to replace one of these wires because of a problem with the circuit. Twice I've had a patient who has left the operating room, and after the operation, even though we saw good numbers, turns out that we had an open circuit. And we've taken them back to surgery, and it was the wire that goes down the neck where we found the problem, and we've repaired it, and we didn't have any problems after that. But again, that's 2 patients, so 0.5% risk. And then seizure. We've had, I think, 2 patients who've had like a convulsion, and then 5 other patients with some kind of twitching that we call a seizure. These 7 patients were started on medications. They continued taking the medications for about 3 months. When this happens, it's usually within the first 2 days after the operation. So these are good numbers. They're low risks, but these will happen again, and they can happen to you. So this is a teaching hospital, so the operations are performed at St. Joseph's Hospital and Medical Center. This is the same campus as my office. We're under the same roof. It is a teaching environment, so residents participate, and they open and close, and I place the leads. So one thing I've been exploring and doing a lot of in the past few years is so-called a sleep DBS. And what that means is we can do the surgery under general anesthesia. Patients are asleep, they can take their medications on the day of surgery. And the premise behind this is the assumption that we can pick the appropriate target on MRI, and that's an assumption, and that we use intraoperative imaging to verify that I hit the target, that I have an accurately placed lead. So there are a bunch of assumptions in the world of DBS in terms of how we proceed with the sleep. But as I note here, it's considered off-label for Parkinson's and for tremor because we're not actually testing tremor arrest at the time of surgery, for example. So when I talk about a sleep DBS, I always include the caveats in terms of what to expect and what's kind of standard nationwide and worldwide. You can see here in my volume, in my experience, I started this back in 2012. I learned this technique from Dr. Kim Burchell, and I'll talk about his work in just a second. And to date, about the number of patients who undergo this operation asleep ranges between 55 and 60%, and then awake about 45, 40%. And I feel equally comfortable performing both of these, but these numbers represent 721 leads that I've placed in 394 patients. So just a little bit more than 50% of my patients undergo this operation asleep. And what we talk about is the sort of risks, benefits, alternatives, indications of surgery. And when I talk about asleep, I make sure that you understand sort of the opinion sort of nationally. So one thing I give you is this article that I printed offline. This came out last November on this website from a practice in Denver that states no data to support a sleep DBS is as safe and effective as awake DBS. So certainly some people have this, believe this, and I'll show you the website right here if you want to take a look at that. What we're doing is we actually follow patients. We get Parkinson's testing 6 months after surgery, tremor testing 3 months after surgery, and we're prospectively evaluating and studying our outcomes with asleep. And from our experience, I think that it's equivalent. I can't tell the difference between leads that have been placed asleep versus awake. And we have a randomized trial as well, where we can, if patients enroll and volunteer to participate, we'll actually randomize the assignment of asleep versus awake surgery. And that is one way we can test to see how they compare. And like I alluded to earlier, the operation that the technique I use, I learned about 3 years ago with Dr. Kim Burchell. So this is another article that I show you, kind of highlighting the work that was done up in Oregon. Dr. Burchell was the first neurosurgeon in the United States to do deep brain stimulation back in 1991. And he developed a lot of the techniques for doing it awake. And you can see here, this is some media covering his work back in June 2013. And basically, there's a lot of interest in exploring doing this under general anesthesia, but whether awake or asleep, we've been looking at doing asleep for certain indications, such as patients who have claustrophobia, uncontrolled high blood pressure, chronic back pain that will interfere with being able to really reliably test them in surgery because the back pain, laying on the hospital bed isn't feasible. Obstructive sleep apnea, and obesity. So things that might be a challenge for the anesthesiologist. So that's sort of in a nutshell what I talk about in clinic about deep brain stimulation. I hope it helps, and hope to see you soon. Bye.